Hi, my name is Monica Moore, and my nutrition proposal today is on nutrition education and sodium intake in CHF patients. A little background: congestive heart failure, CHF, affects 5 million Americans. Approximately 550,000 new cases are diagnosed each year, and of these cases, approximately 50% of these patients will die within 5 years of diagnosis. CHF also costs Americans between $30 and $32 billion per year to manage. Standard CHF recommendations include a low-sodium diet, diuretics, cardiac medications, daily weight monitoring, and a fluid restriction if needed. Looking at current literature, there are lots of studies out there looking at the sodium intake of patients when it comes to nutrition education and congestive heart failure. A systemic review of 17 previous studies over 10 years done by Abshire et al. Shows readmission rates were positively impacted by nutritional education when a food recall questionnaire and 24-hour urinary sodium excretion tests were studied. 100 participants in an Iranian study showed the difference between sodium intake with nutrition education without. After 6 weeks of education and sodium intake levels measured pre, post, and 12 weeks post-intervention, a significant difference in sodium intake between the groups was seen, and also a significant difference in attitude, adherence, and behavior were seen as well. From the same Iranian study, you can see the average sodium intake of the control group was about 3,000 milligrams per day, which, as we just showed with a low sodium diet, the American Heart Association recommends 1,500 milligrams per day as the average recommendation. So this is double. 3,200 milligrams was the starting point for the intervention group and dropped down to 2,500 milligrams by the end of the study as the average, which is a significant improvement. Other studies, including Butler et al., which is a randomized double-blind control study using the Prohibit Sodium study, sent prepackaged meals to their participants for 12 weeks with either low 1,500 milligrams or high 3,000 milligrams sodium amounts in them, and then after that followed them for an additional 12 weeks to see what they self-selected and then reported their sodium intake to be. While they expected to see a lower sodium intake amongst the group that had been originally sent the prepackaged low sodium meals, they found no significant differences in sodium intake between the groups when they chose for themselves, and they found nutrition education on sodium intake to be a large barrier in seeing those expected results. In Dunbar et al., looking at the effects of counseling and education on nutrition and self-management, 2 nutrition education sessions were done in the hospital and 1 on a phone visit afterwards, showed improved knowledge about CHF after the 30-day check-in, but by 90 days after their hospitalization, their knowledge level had returned back to baseline, which shows that there is not only an improvement from education in their knowledge, but also a need for more than just 2 sessions in order to maintain that knowledge longer term. Seed et al. Did a survey of 310 participants and showed that CHF recommendation adherence is quite low. Overall, they saw a 22.3% adherence rate to recommendations and only a 64% reported adherence to low sodium diet. This brings us to our research question. Does nutrition education improve sodium intake amounts in patients with newly diagnosed congestive heart failure? So the newly diagnosed congestive heart failure population is one that there is a literature gap about. While there is research around education, sodium intake, and CHF patients, there is nothing specifically about this newly diagnosed population, which, as we just discussed, only has a 50% survival rate for over 5 years. Objectives of the study will be to determine if regular structured nutrition education can improve compliance to a lower sodium intake, and the research could be future applied to practice and developing standards of care that include nutrition education to lower CHF costs and mortality, especially in that newly diagnosed population. The methodology and design of the study will be an experimental quantitative study, case-controlled and randomized. A 24-hour urinary sodium excretion test will be the data that's collected. It will be done pre and post study period, and the office staff in the doctor's offices will actually collect, code, and send this information to the researcher via e-file. A G-power test will be used to determine the needed sample size to assess significance of the results. An independent t-test will be used to determine if they are in fact significant results, and we'll be comparing pre and post urine sodium values for each group and then also post-study values between the groups. NCSS data analysis software will also be utilized. Participants will be newly diagnosed CHF patients invited to participate at their outpatient doctor's offices during their regular scheduled visits. New CHF diagnosis under 6 months and over 18 years of age will be the population we'll be looking at. Exclusions will include being under 18 years old, existing CHF diagnosis over 6 months, missing scheduled appointments, and any hospitalization during the study period. Recruitment will occur in the Portland, Maine area within the Maine Health Providers' offices and cardiac clinics. The graphic shows the Maine Health hospitals, and within each hospital they have their own providers' offices and clinics, so it'll give a wide variety of demographics and income levels. Potential participants will be coded by the Office for Confidentiality and their information passed along to the researcher for inclusion and analysis to protect their confidentiality and adhere to HIPAA. At least 45 participants will be recruited per the G-Power results, and no monetary incentive for participating will be provided. Participants will be randomly assigned to either the control or the intervention group. Initial 24-hour urinary sodium excretion tests will be done on all participants to establish a baseline. The control group will receive the usual standard of care for CHF management, and the intervention group will receive the usual standard of care and physician's office appointments, as well as 6 weekly dietitian visits for low-sodium diet education and support. Counseling sessions for the intervention group will occur in the office and be coordinated the same day as their already scheduled physician appointments in order to improve compliance to attendance. One 30-minute session with a dietitian will happen each week for 6 weeks total, plus additional dietitian troubleshooting and support available in between for participants in the intervention group. Post-study 24-hour urinary sodium excretion tests will be done at the end of week 6 in both participant groups. We anticipate to see a weekly nutrition education counseling program decreasing sodium intake through comparison of a 24-hour urinary sodium excretion test. We anticipate to see improvements from start to finish in the intervention group, and we also anticipate to see a significant difference between the control and the intervention group at the final urinary sodium excretion testing. Limitations of this study include retention of the participants throughout the study period in order to achieve the optimal sample size by the end, and some confounding variables to consider will be medications, previous CHF knowledge, previous diet knowledge and habits, motivation to comply, fluid intake, and other existing medical conditions. Informed consent will be provided to the participants prior to their participation. Description of potential risks and benefits will be given, and risks will not outweigh the potential benefits. Participants will always have the option to decline participation at any time before or during the study. Final ethical consideration, the control group will still get the standard of care for CHF management in order to remain ethical, as the management of a chronic disease is considered a vulnerable population. Finally, a research ethics committee review will be conducted at the hospital level in order to assure ethical considerations throughout the course of the study. Thank you for consideration, and here are some of my references.